All right, so like I said, we're going to just talk briefly about case reports. The goal of this session is really to help you figure out how to do them and get you started. I will have some pauses in here where we can talk about the cases a little bit. Folks from the VA, you're welcome to buzz in. I guess I don't know if that's the right word. And we can do that. And then also, there are additional resources that I can make available to you after this. We're recording this for people who couldn't be here for Night Float so that they can sort of review this and help with it. All right. So I did notice that I call it the gateway drug to medical writing. I don't know why that made me think that was funny, but I did think it was funny. But y'all know me and I think I'm funny. Okay, so the idea for this is really for you guys to have, to learn really how to identify a case for case presentation, to develop learning objectives around that case that emphasize your main teaching point, and then recognize that there's a backwards approach to writing a case report that might make it an easier process for you. All right. So just as a credit, I got all this off of MedEd Portal. That is a site for for medical education, curricula and things. And so for most of the slides are from the first reference, Christy Moore, who had done this for the Carolinas, and she does a series of these for her residents. And then our friend at Bay State, Mike Rosenblum, has also done a curriculum. So these are available. And you guys can sign up for MedEd Portal and get downloads of educational material from there too. All right. So really we're going to go through an outline of introduction, selecting the case, developing sort of the authorship, which I think is an area of confusion a lot, and then trying to write a case report by section, and then just a little bit about references. All right, so first of all, why write case reports? When I did this for faculty, this is what we said. You know, we want to promote academic thought. For you guys, we really are wanting to aid you guys for fellowship direction, for fellowship applications. You all have to have a scholarly project in residency for internal medicine, so that's an easy way to do that. Almost all of this is easily adaptable in the same process as you would use for posters, and so that's why I'm doing that today, because I think the ACP deadline is maybe tonight, but a lot of you are doing a poster for the ACP, and so having some of this to flesh out the rest of that past the abstract will be helpful. And it is a gateway drug to more medical writing. They did do a study that was published in Medical Teachers where doing things for writing and editing, including case reports, actually promoted more and further medical writing. And so it does teach you some of those same skills that become more important and easier later. All right. First of all, selecting a case. When you guys think about a case, what kind of things do you think about would be an interesting case to present? Not the specific case, but in general, when you say, oh, this would be a great case for a case report, what kind of cases are they? Go ahead. You can shout out. You don't have to be formal.
A unique presentation of a common disease.
Okay, so unique presentation of common disease. That's great.
Something really rare.
A rare thing.
A physical exam finding.
A unique physical exam finding. Great. The VA's got nothing. That's all right. Okay, so these are the three categories in general. One is diagnostic and assessment, which is really what you guys were talking about, presenting an unusual case or challenging diagnosis or something like that. Treatment and management can be a case report also, especially when it varies or it's complicated. You could not use this treatment because the patient had a contraindication, and so you had to do something else that worked or didn't work. That would be a case report. And then there's the educational, where they use a case to teach sort of principles. This is sort of like the clinical pathologic conference in the New England Journal of Medicine, where they present a case and they say, here's your differential and here's the learning things. That's becoming really pretty uncommon. The New England Journal does it. None of us submit to that. They pick these one place that does it. The Journal of General and Internal Medicine does some of these to teach the thought process about making diagnosis and things like that, but those two are not things that are submitted, but those are things that are requested from specific people. So sorry. So that makes the last category sort of uncommon. So really we're left with the things that you guys mentioned, the unusual diagnosis, assessment, or some sort of treatment change. So here's some other ideas. You already mentioned a lot of these. Increase awareness of a condition. So I know someone is thinking about that from the outpatient center, that an isolated lab abnormality was not really considered, and it ended up being a sinister diagnosis. Talking about cost effectiveness, that is an appreciated topic now. So if you have a cost effective way to deal with something, or to describe a rare or usual complication of diagnosis or treatment. I think Ryan had one of those last year at the ACP meeting. I can't remember what it was, but it was bad. Yeah.
Oh, yeah, the really red rash.
A really bad rash. So, from chemo. All right. So one thing I do want to caution you with is to really scrutinize the case before you do it. Lots of times we go and we think, oh, this is a great case, and it's this thing. And I've been burned twice now, so this is why I'm really giving you this caution. The first time when I was in residency, I passed it by someone. They said, yes, it's a good case, do that. And then when I presented it, I was ripped apart because it was not as clear as I thought it was. And that was really because of my inexpert abilities. The second time, we did have a consultant tell us, yes, this is a good case, yes, this is it. But whenever we sent it in for review, two other experts said, I don't really think this is the diagnosis. So when you do something for a case, I'm not trying to discourage you, but really do due diligence to figure out this is actually what the case is about, and there's not, you know, what are the other things in the differential? How have you proven that that wasn't it? That sort of thing. All right, so this is a time when we stop, and if people want to talk or want to say, I have this case, I'm thinking about this case, I need help with a case or something like that, would this be an appropriate case? We can do this. If you guys don't want to do this in a group, that's fine. But if people, like when I did this with the faculty, we had a couple of people talk about things, and sometimes there were not cases appropriate for case report, but for another venue or something. So is anybody struggling with this part? Jared?
For me and Christian have a patient that we've been writing up. The problem is that it's unusual, but it's not rare. It's been documented once or twice before. So he had hypermonism from chronic Mucinex.
Yeah.
You know, he has some psych issues. So I looked, doing the literature search, there was like one or two patients that has actually had bromism from this exact same thing, from you know, cold medicine, taking it chronically. So it's rare and something that we never even thought of until the nephrologist came by and was like, wow, this dude has a negative anion gap, this is a thing, you need to bells and whistles. You know, since it's not, if there is a paper on it, there's a report on it, does that still count, or is it a need for a poster to find, or something that they need for a journal?
Sure. So Jerry's question is, they've had a patient had a negative anion gap with bromism, and it's been described before. Is that still a good case report? The answer is yes. It's still a good case report because it's definitely a poster for the ACP meeting and that sort of stuff. I think the problem that I happen to know about that one, because you've told me about it, is that you guys don't have a bromide level, and so you may get shot down by some journals, and I'll talk about like how to figure out the journals to submit to and some of the pros and cons of that in the past. Yeah, no, that's okay. So that was the downside. That's the one thing when I was saying vet your case. Like, do you have, like, if they had a bromide level, it would be a slam dunk case report for sure. And there are places where they do it like a quick report, which is not as thorough as a case report, but that sort of thing. So yes, I think that is still, even though it's been described before, you can do that. I made the mistake. We had a patient with emphysematous cystitis on wards, and I was like, oh, it's been a case report. We won't submit that. And then 6 months later, I saw it in a journal. I'm like, really? You know, so we could have had that 6 months, you know, or 6 months or a year later. So yes, just because it's been described before, it can be a case report. It's extraordinarily rare that you would have a case report that's never been reported before. And so if it's had 100 case reports, then you probably won't have an audience. But if it's had a handful or something, for sure, it's still a case. Tyler?
You're talking about the educational one not being as common for case reports now. For something like ACP, where I have a patient whose diagnosis is either really rare or relatively uncommon, but it's not completely clear yet, is that still an okay venue for an educational description and workup and kind of how you get where you landed?
Yes, so Tyler's question was like, if you have a case and it's not sure yet, can the workup and the diagnostic approach be a poster? And the answer is yes. For the ACP meeting, that's definitely something that can be done. That can be done for some, like the regional general internal medicine meeting, which will be in Houston this year. Maybe could be a poster for there, maybe not. For the really bigger meetings, that probably won't fly. But that is something that you could do and submit. And I don't know that the ACP meeting in Kentucky rejects anything. So, but I don't think that they have a peer review, as far as I know. So I think that yes, the diagnostic approach to that could be something. So when you think about your case and you think, okay, this might be a really good case, start by jotting down a brief outline. And the key thing to think about is, why did you pick this case? Why was this interesting to you? Why did you think this was going to be something why did you go, oh, this is a great case? Once you pinpoint that thing, that will drive the rest of your workup for this and all your work related to that, and so that really becomes a big thing. The other thing is develop a teaching point. So that is something different than what we're used to in research and some other things. Is what do you want somebody reading this to realize that you didn't know when you started out? What was the thing that you learned and you think that is a really key thing? This will end up being your roadmap. All right. Reviewing the literature. Please review this before you start writing. For some of the reasons already alluded to, if there's 100 case reports, you're probably not going to get another case report to it. But also it can help you focus, how this is similar or different than past cases. So that is an important thing to do. Remember that we have a librarian that works with us, Vida Vaughn. She comes to Newman Report at university on every post-call case. She's there every time. She's there oftentimes. She's very accessible by email. You can just email her and she will help you with a literature review. So I think you should also do your own, because sometimes the way we search and the way they search is different because she doesn't have the medical knowledge. So let her do a search, you do your own search, and then you will find a really good set of info before that. Realizing that you're not going to use all these references. So also, just a caution, please use the primary literature. No up to date. Nope. Medline, PubMed. The National Guideline Clearinghouse, if you're not aware of that, it's just has all national guidelines in one area where you can search by disease state. And then the Cochrane reviews are evidence-based reviews of large subjects, and they're actually very high quality, and so that may be someplace else to look for some literature for you. Try to narrow your focus when you're doing your lit search about what is unique to your case, and that's why you have to have that roadmap first. Think about that. What are you trying to reach? What are you trying to teach? And then use that in your search so as you're not drowning in thousands of papers. All right. A learning objective is basically a statement in really specific terms about what your reader or what your learner will learn from that. So at the beginning of this, I told you we're going to have you become familiar with the backwards approach and learning objectives and things. Those were my learning objectives for this talk. Same thing for a learning objective for a case. What is it that you want them to recognize? Recognize a negative anion gap. Bromism should be in the differential for a negative anion gap. Or something else should be in the differential of a polyneuropathy or something of that. So think about what you want them to be able to learn, and it should be things. So these are called Bloom's taxonomy examples, and this is in education, but specifically in medical education. And they're different things. For case reports, it's mostly going to be in the cognitive domain, analyze anion gaps or analyze blood gases to be able to learn something, or evaluate or create or remember or recall or something like that. There's the affective domain, which we don't talk about that, but that's things like appreciating, and that would be ethical issues, valuing patient input, something like that. And the psychomotor domain doesn't apply to case reports at all. That's things like teaching procedures and things like that, so performing, precisioning, that sort of thing. But those are all examples, and so when you're making your learning objective, you should be able to use one of these words. And if you Google Bloom's taxonomy, you'll get a list of about hundreds of words, which is why I didn't put it all up here so that you could actually see it, but you would be able to find some that fit for your case. So here's some learning objective examples, like describe the key clinical features of anorexia and bulimia in a male, define specific features of health illiteracy in at-risk populations, and diagnose hip fracture when x-rays are normal. All right, so do you guys have this is like my stop, and do you have any questions? Do any of you have something where you have a case but you're really struggling with what to focus on?
This guy who came in, he had allogeneic stem cell transplant when he was a kid, I think, like 1 year old. And then he had this weird history of recurrent mucocutaneous candidiasis and was losing all his teeth. And then he had laryngeal cancer, elite. Anybody that has some secondhand smoke exposure. And the reason why he was actually admitted is because he had adrenal insufficiency, and they thought he might have had histoplasma, which caused him to have the adrenal insufficiency. So at this point, I've been sitting on it and I don't even know which part is to lay down.
Okay, so Jared's example for the people at the VA is patient with stem cell transplant, recurrent mucocutaneous infections, and then now comes in with adrenal insufficiency. So what do you focus on? Input from anybody? Like, was it the medicines that made him adrenally insufficient, or the infection?
I believe it's the infection.
The infection. Okay.
Anything for a while.
Zero input. Thank you. I mean, I would think in that situation, if it's thought, like, I think, one, you have to go back and really look at the case and talk to your consultants. But if histo's causing adrenal insufficiency, honestly, how many people knew that in the room? One. Okay. So there's a case, like, that would be a good focus if you think that that's a fungal disease, if you can figure that out. So you can't, the problem is you can't take all those weird things that he's had, because he's had a bunch of weird things. You got to focus on one weird thing and figure out, what's the teaching point. Anybody else struggling with what to focus on?
I just have a side note about the primary resources for literature.
Yeah.
The clearinghouse resource, that's no longer available.
Ah, okay.
Yeah, they decided it's not for...
Okay, so BJ says the National Guideline Clearinghouse is no longer available.
It's not online.
That's a bummer. Okay. All right. So defining authorship, I find that people really struggle with this a good bit, like who should be an author on a case. And so there are things, there's the ICMJE, which is the International Committee of Medical Journal Editors, I think that's right, authorship recommendations. And so they're actually, one, there's actually a group of those people, but two, they also have recommendations. And one of the things is that you should be significantly involved in the design or implementation of a project, or in this case, the case report. So that means maybe you were involved with a team that was taking care of it, or somebody who's trying to write it up. If you are not directly involved with the care, that does not mean you can't write it up and be involved. So that's not a necessary thing. You should ask the teams about, if somebody else wants to be involved. The other thing, you should be involved with writing and or the critical content revisions. So, you can be the person that looks at it and goes, no, that's not clear, or here we need to do this or that or the other. Those are all things. Final approval of the version to be published. Almost every journal will say, actually when you submit to the IRB, but also when you submit to the journal, they'll say, just everybody aware of this, and they agree to it, and you have to actually log in and sign on to do that. And then finally, accountable for all aspects of the work, including accuracy and integrity, meaning you all agree that you're not cheating and making this up. Okay, so don't do that. That's always bad. And then finally, as I mentioned before, please discuss with the clinical team about that. There have been times when somebody in the clinical team was thinking about writing it up, and somebody who was maybe interested in that especially heard about the case and wanted to write it up. And you can collaborate. It doesn't mean, you don't have to have just one author on a case report. All right. Any questions about the authorship that you guys have encountered or had some trouble with? Yeah. Many teams are involved.
Yeah, what about, for example, the media team is involved, the other team is involved, and who
I think in that's a really good question, because that happens on a lot of complicated patients. Like, what do you do when there's lots of teams involved? I think you need to just touch base with everybody. It may be that if ID has one aspect of the case that they want to write up, and GI has a different aspect. So they may have an interest in the case, but different teaching points, in which case you could have two different case reports. But in that situation, you might do something where a lot of you are involved, and that's okay. If there are 15 authors, that is probably ridiculous. But, not everybody's going to be willing to do the work. And some people may say, yeah, I want to be involved with that, but never actually follow through with it. And in that case, they're not an author anymore. Fair?
So we have a case where our annual team at the VA was involved, and then one of the primary medicine teams were collaborating. Then we found out that pathology is also interested, so they may take a different direction. Are they able to still submit, like you said?
Yes, yeah. So Farrah's asking about, renal and primary medicine at the VA are interested in case, and found out pathology is actually interested. I think you have to talk to people, because you want to see if you're all talking about the same thing. Pathology might be why it's a difficult diagnosis and why this is, what characteristics make this slide one thing or another. I have no idea. Whereas, from the clinical side, you may say, here's your differential, and you get this pathology back, and here's how you fit that into the clinical context. So it could potentially be 2 case reports. You have to really just talk to the other people and say, what's your goal? What's your learning objective? Where are you guys going with that? And there's no reason to not collaborate with pathology or other services. Anything else? Okay. All right, writing a case report by section. I found this really, really helpful when I found this, or actually I went to this workshop that Christy did. And so this is your standard case report. Basically, you're going to have a title, an abstract, sort of the case presentation, and then a discussion about it. A conclusion like, don't give steroids to, give steroids to people who are septic or whatever it is. References and acknowledgments. But whenever you're writing, there's sort of a backwards approach that makes it a little bit easier to do. The downside of that is that you have to do some of this work ahead of time. And for instance, the ACP just asks you to do an abstract. And so because you guys are time pressured, you do the abstract. But if you're writing a case report to be published, this would be the way to go. So if you're going to write by section, first of all, you begin with a case presentation, then create the discussion, then talk about the introduction, the conclusion, and the abstract, and then give them a title and work on your references. In the case presentation, you want to describe it in chronological order, so how they came in. Avoid abbreviation, so we abbreviate it a lot, like OSH here means outside hospital. That is not a real thing out in the publication world. Only include the pertinent negatives, so remember you don't want the case to be so long that it exceeds the word limit for the whole case report. So you're going to try to be terse and just give the pertinent things. Be very specific and try to use as much objective data as possible and use units. So we say the creatinine was 2, but the creatinine was 2 milligrams per deciliter, right? So you're going to be a little bit more formal in that way. And then if there are abnormal tests that you don't know about, like they're not the common things, like we all know what a creatinine 2 is, but we may not know what a normal for, give me something, ANA would be. And then describe the response to treatment and state the outcome of the case, unless that is really not the not the part of the case that you really want to focus on. One key thing is about this is notice that you use past tense, so the patient presented with instead not current things, not current present tense. Sorry. De-identifying information. I don't think anybody would ever do this on purpose, but when I saw this slide, I started getting freaked out because, names, fine, I wouldn't put their social security number on there. But things like people who are over 89, because they're so rare, you shouldn't say their actual age. Because if they're a 97-year-old with, bromism, how many people are those? That's 1. So, that was something I had never really thought about. You're not going to talk about the admission date or sites. Geographic divisions, like you can say an urban academic medical center, which would be us, or a patient in the South, if that's, pertinent and things like that, but you wouldn't say in Louisville, Kentucky at University Hospital or things like that. Any of these other things, phone numbers, any identifying data, anything you could put into Google and find in a search if you paid $10, those are all things you shouldn't put in there. And then things like certificate numbers, URLs, internet protocol, address numbers, which you can get from IT and stuff. And then things you already know about, like full face photographic images and things like any kind of other characteristic or code that might identify a patient, like a tattoo that has their prison number on it or something like that. This is something that's very logical, but I had thought about. Be respectful of your patients when you're writing up a case. And I don't think any of us are trying to be disrespectful, but in the literature world, you don't define patients by their disease, so they're not a diabetic. We say that all the time, but in the literature, that's frowned upon. You wouldn't say they're an addict or an alcoholic or a manic depressive or asthmatic or epileptic. Instead, you would say a man with diabetes, a woman with epilepsy, things like that. Other thing is don't blame your patient in writing. These following statements imply the patient was at fault, and if they would have tried harder or done something different, they would have had a different outcome. I've never, ever, until I read this, thought about this in this way, but it does make sense from a literature sort of way. So the patient did not respond to conservative treatment for the arthritis. You would say instead something like, the patient's arthritis pain was not relieved with conservative management. It's just a small wordsmithing thing, but the editors will shut you down for this. The patient failed chemotherapy. Instead, it would be the patient's cancer did not respond to initial round of chemotherapy or something. All right, so I want you guys to select the best worded statement and tell me why. I hear nothing. B, thank you. Okay, so why is it B? So you don't say diabetic man, it's a man with diabetes, correct? And, oh my gosh, I'm so sorry. Yeah, he didn't fail anything. His glucose was not controlled with his oral regimen. Right, so that's how you, it's just a small thing, but this is really a way to show respect for patients in your writing. All right. So thinking about the writing of this, by section, first you've dealt with the case presentation, and now you're going to talk about the discussion. So thinking about the discussion, it's not an exhaustive literature review. Most of the journals will limit the number of resources, the references that you can do to something like 5 to 7 or something like that. So your idea is to really focus on the lesson, and whatever literature is available, you would bring that in your discussion. You're going to compare and contrast to other case reviews or other articles out there. So if your patient responded to something that's not the usual treatment, then you would say this is the usual treatment, or this is the guideline that goes with that, but they didn't respond, and so that's how this is different. So you just want to reference sort of other case reports in the literature, sorry. If there's another possible diagnosis, and you don't think that's it, you need to talk about why that's not in. So not only just, we think it's this, but here's why it's not these other things. That's an important thing in the literature. And I don't mean by paragraphs of this, but, just the mention of it in a sort of compact way. And then finally, discuss any teaching points or pearls that you thought were important. That's going to be one of your conclusions in the discussion. So you've done the presentation, the discussion, and then you're going to move on to the intro, the conclusion, and the abstract. The introduction really serves to introduce the topic to the reader. And so you're going to use present tense verbs because it's about what's happening now and why this is important now. And there's something called the funnel approach, which I really hadn't heard of, but it's super helpful. So the funnel approach is thinking about what's known, what's unknown, and why this answers the question and why this was done. So that is sort of an approach to all writing, not just case reports. So if you're thinking about case reports, the background and overview would be like, what's the importance or magnitude of this problem? In the background specifics, you're going to say what was specifically not known, what are any knowledge gaps, why is your case unique or novel? So that's what's not known. And then how does this fit in is why your case is valuable, like defining teaching points and defining your hypothesis. The conclusion is the take-home message, the thing you want them to learn. So when you're using the same process for making a poster, this is the last thing on your poster, right? This is the thing that when you're presenting, you want that judge to walk away with. Focus on the teaching points of your case. So think about what you're doing. You're writing everything to come to the conclusion at the end. So it should be bridging into that. It shouldn't be that you bring up a conclusion that nobody's talked about in the rest of the paper or the poster as far as that goes. You can always talk about suggestion for future study if that's applicable. And then give up any follow-up information like on the pace or the outcome of the patient and that sort of thing. The follow-up information would not be applicable in the conclusion part of a poster, but that is a part of the case report necessary. And then the abstract should really be written last of all your big writing, and this is basically the condensed summary of your case. So what you're going to do is just take the key points from all those other things and bring it down. There's almost always a word count. It's almost way less than the rest of it. And so you have to think, what is someone going to search if they are going to look at my case report? If they're going to put in a literature search and my mom wants to read this, what will my mom have to put in to be able to find this case report? So that's something to be done last, because at that point you should have really refined your writing and gotten it so that your teaching points are well fleshed out. One key thing in this, and actually everything, do follow the journal's author guidelines. They have very specific things like font, spacing, size of the font, how many words, etc. Whatever they say, you need to do that, because sometimes if they get a lot of case reports or get a lot of papers, they'll just reject it because that's the easy thing if you fail that. All right, so we've gotten through all the hard parts, and now you're going to do the title. Try to be specific. You can name the disease, condition, or problem and talk about the population or why it's rare, but also don't give everything away. Also, don't make it so catchy that it's weird. So, like, I think catchy phrases and puns are funny. I personally love that sense of humor, but not everybody shares my sense of humor. So if you think about you're going to really have to do that, think about that maybe as a subtitle. And then be really clear, concise, and relevant. You don't want your title to be really, really long. So try to think about how it best describes the patient in, 10 words or less. So here are some examples of titles. Stones in the missing gallbladder, chlorpromazine-induced hepatitis, STEMI mimic on EKG, the Brugada pattern. That kind of does give it away unless you don't know what the Brugada pattern is. Persistent breast erythema, and then code status in the perioperative period. Those are all real-life case titles. So finally, you've done all the hard work, and now you just really have to think about references. How many of you have ever used a reference management system like EndNote or that sort of thing? Okay, so actually a number of you. So that's actually really helpful. If you want to learn how to do that, Kornhauser does sessions. They're usually at a time when no resident can go, but if there's enough interest, we can have them come here and do some with us. So if there's an interest for that, let me know. But when you're doing references, you want to cite the primary literature, so not up to date, not things like that. Books and printed tests may be okay if this is something that's really old, and not likely to change like a solid thing. Avoid citing clinical reference databases like up to date and that sort of thing, and things like magazines, news articles, blogs like the late literature. Try to focus on landmark or seminal articles, things that are well known, and the most recent things if you have a lot of references. And then key thing, don't cite an article you have not read. So I was writing a paper recently, and it looked like from the article I was citing that the way they used it in context, they cited another article. I'm like, well, that looks like it fits perfectly. And I pulled the original article, and I'm like, how did they ever get that in the first place? So be sure to look at the article you are really citing and make sure that it is pertinent. These are the reference management softwares. Zotero is one that's free. I have no idea how it works. I don't know if it works well or not. Has anybody had experience with that? Okay, I don't have it either. Oh, you have? How is it hard? No. Oh, perfect. So it's free and easy, so that's great. EndNote, you can get through Kornhauser here, so you can download that, and it automatically brings in the article and will automatically format it. And if your author says they want it in MLA format, it'll do that. It'll change your whole paper into that. If it says, no, we're going to resubmit it because somebody didn't like that and we need to do it in AMA style, you can just hit a button and it reformats it. So it does cut down a lot of work later if you can use the reference management softwares. There is the National Library of Medicine where this ICMJE works, I guess. And so they have a lot of reference formats that you can just go and look at this website. And the AMA manual style has a lot of things if you're looking for that. But the Kornhauser site or those librarians can actually help you with this. Useful information and resources. Here's some publishing tips from Boston. There is a big push about not doing plagiarism. I know my kids in high school had to submit to a plagiarism website, and it would check to see how much you guys are nodding your heads. Apparently this is not new. But, like there are ways for people to do that. And I'm sure that the journals actually put your stuff through that. So don't quote, don't lift whole parts of a paper from other people. And then there's this self-check program, which you can use as well. One question comes up is like, how do you find a journal for that? This is something that I have tried, the journal author name estimator. And what you do is you put your title in or your abstract in, and it looks at it, and then it will give you a list of journals where you could potentially that have had similar things. And so this is available through the Kornhauser website and also just online. When you click on that article, it'll say, show me the articles, and you can see what the articles are about. So it's been a little bit helpful to me. There are, this Google site that Dr. Moore put together has a lot of things. The key thing about case reports is that you need to look at the information for authors because some of them cost $2,000 to submit if they accept it. So you don't want to submit there and then they say accept, and then you have to pay $2,000 for that case report to get, published. There are other ones that don't have that. There are ones that take it and have no costs associated with it. So be sure, if you look at one of those journals through the Jane site and you're like, oh, here's 3 or 4 that seem to fit, be sure to make sure that you have looked at the information for authors and you're not going to be out. Because I know you're going to be surprised by this, but I am not going to pay for your $2,000 case report submission. I'm just not. And then these are things, the ICMJE about recommendations for editing, publication, and scholarly work. They just have some other references there for you if that helps. Things that go without saying, no plagiarism. I don't really expect that. Read the references yourself. Look at the editor's comments. So they will send it out for review. So I've done some review on a case, and I sent back my review, and that person should look at that. So somebody who's saying they were anemic from bed bugs. Now, we have seen some bed bugs in this place, and we've seen some anemia, but not too many of those causing that. And it's not completely implausible, but the person didn't make a case for it. So when you get the journal editor's comments back, look at that and see, can you make those changes or not? Sometimes you'll have to just submit it back and say, we don't have that information, we don't know. Try to abide by the author's instructions. There'll be things about length, style, paragraphs, formats, figures, how many you can have, that sort of thing. Those are all important. Please send out correct grammar if you're not a great writer, and that's fine. There are a lot of great doctors who are terrible writers. Please send that to somebody you know or love, or that know or loves you, who's better in grammar. And just find those sorts of things and make sure that it's grammatically correct. And then don't overstate your case. I think one thing is people are like, oh, here's what happened. And sometimes we don't really know. So be sure that your conclusions match what the actual data is. And then the final thing is do not submit to more than one journal at a time. That is that is unethical and completely frowned upon. People ask me, can you do a poster and then do a case report? And the answer is yes, because there's 2 different mediums and they're 2 different situations. So lots of people will do a poster and then do a case report, or a poster and then a paper, a publication for research. That is not frowned upon. But you should not submit your paper to 2 different journals at the same time. Most of the time when you submit to a journal, you have to attest that you haven't already, it's not in review somewhere else, and so they make you go through that process automatically. And then maybe think about the journal, going back to that Jane research website, and think about, okay, where is this best suited? What audience is this great for? Some things would not be good for a subspecialist, but might be great for a general internist and vice versa. So think about who your audience is and then target your journals accordingly. For the IRB approval at U of L, any case reports or posters have to go through the IRB. You submit it as a case report, and if it is less than 5 cases, it will be waived. It doesn't take long to go through this. Dr. Sharp sent this out, and we can send it back out again. I almost gave you screenshots, but it ended up being 14 screenshots, and I just said, forget it. So we do have that available for you, but the IRB has tried to streamline this so that you would have that. When you get the IRB number, you can say in your paper or on your poster that it is waived or is deemed non-exempt by the IRB, and then every place will say that it's acceptable to submit to them. That is an important thing. So just because you have a case and no identifiers does not mean at this institution that you can submit a case report or that you can do a poster. So if you have a poster going to the ACP, you need to send that abstract or send that report to the IRB. For those of you who've done that, how long does that take to do?
10 minutes.
Yeah, it's 10 minutes. Well, it's not very long. Okay. All right, so last thing, does anybody have any other questions or input or want something about a case? Tyler?
You said nothing more specific than year. So a timeline is important. I have like recurrent pleural effusion, and you may have like a pleural primary lymphoma, or maybe not.
Yeah.
But the workup was like this primary care doc like auscultate. That's how they found the infusion. It's got a bunch of like thoras and X-rays and CTs and smoke imaging. Would you just put like a time 0 and then like months later, like how would you arrange a timeline?
Yeah. So Tyler's question is, what do you do for timeline when that's an important part of the diagnostic and workup? I think you can say the patient presented with these complaints. Here was the initial workup, 3 months later, 6 months later, 1 year later, that kind of thing. And then you wouldn't have to specify the year. The year is important for some things, like back when HIV was first starting to be an epidemic and that was unknown, and then we had some people who were resistant. There were case reports about people who had HIV but didn't die from it. And so a timeline then would be, diagnosed at the beginning of the epidemic or whatever and were alive 10 years later. But you still can be like in the early 90s or, something like that. So you can be a little bit more vague.
Case reports, if you've been kicking one around since med school and you went somewhere else, does it still go through this IRB?
Yeah, if you've been kicking around a case report and you from another institution, I don't know that answer. You can contact our IRB people and they would know. There is something called reciprocity with IRBs, and so sometimes you would put it through here and then you would send it to the IRB at your home institution where you went to medical school, and then they would waive it too. But the people in our IRB office are actually really interested in working with residents. Like, you can call them and go over your case or your research or anything before you submit it, and they will help streamline it. So that would be an easy email or call, and I'll give you the contact information for that person if you want to know. Other questions? Did anybody bring cases? Okay. If you brought cases and want some input about them, if you want input about your case or you want somebody to work with it, if some of you want, one thing that you can do is actually help your fellow resident edit it, like have somebody who doesn't know the case look at it and go, what about this and that? That sometimes brings other issues to light. I'm happy to be here after I see Dr. Krishnaswamy, after she's done. I'm happy to go through that with you guys if you want, but I need to know now so I can come back at the end of the lecture. So if anybody thinks that they have their stuff here or they want input now, just raise your hand and I will come back and help you afterwards. Okay, great. I'll be back then. All right, anything. All right, well, thank you all for everything, and hopefully we'll get lots of case reports going.